in the title that actually got put in the program. I've got some handouts about this. I called it Coping with Prednisone because that's actually what I was asked to talk about last year. So this is a bit of a repeat, but new people. And I've got a few slides. I'll talk a little bit about steroids and prednisone, and then we'll answer whatever questions you may have. So I have no financial disclosures. The use of corticosteroids for treating autoimmune disease was introduced at Mayo, and I'll talk some. A Nobel Prize went to the first rheumatologist at Mayo. I've not made any money from this. We'll not talk about off-label use. So what I'm going to cover for you today, and I really don't have, the slides are in the handout, so I don't have many, but we'll talk a little bit about the history of prednisone, talk a little bit about the data of using steroids for treating myositis, and talk some about my approach to managing inflammatory myositis and kind of where I see steroids fitting in. And I didn't mention, I brought handouts. There's some handouts in the back. I left some on one of these tables up front too. And then a chance for you to talk about things, treatment regimens, side effects, and strategies for coping with prednisone. So, on your left is Philip Hench, was the first rheumatologist at Mayo Clinic. And on the right is Dr. Hench, along with Dr. Edward Kendall, who was a biochemist. And they synthesized steroids. So there'd been a lot of use. The story that I'm told is that sort of the development of prednisone goes back to World War II. And there was a lot of interest in the Allied side about having basically performance-enhancing drugs. There were issues that the Germans were working on compounds that would let their pilots fly longer and stay awake longer. And sort of it got this research going of looking for compounds that eventually led to the discovery of the adrenal the steroids. And Dr. Kendall was the biochemist who synthesized these compounds, and Dr. Hench was the rheumatologist who started using them to treat patients with rheumatoid arthritis. And the observation had been that women with rheumatoid arthritis tend to get better when they're pregnant. For other autoimmune diseases, there's a tendency, such as lupus, and often with polymyositis and dermatomyositis, there's a tendency for disease to flare during pregnancy, but women with rheumatoid arthritis got better. So people started thinking, is this some hormonal effect? After they synthesized this hormone, they used it to treat patients with rheumatoid arthritis, and it was that use that actually won the two of these guys, as well as a Swiss scientist, the Nobel Prize in 1950 for the use of steroids to treat inflammatory diseases. And the picture that I had on the first slide is this. The title of this painting is La Cortisone. And this was done by Raoul Dufay, a painter who had rheumatoid arthritis. And he came to the States, I don't think to Rochester, I think to Boston, and was treated with cortisone for his rheumatoid arthritis that let him go on to function and paint. So he painted this and presented the original to Dr. Hench for his use of steroids to treat autoimmune disease. So we have some copies of this. I'm not sure where the original is. We have copies of this up on our floor. So steroids are very effective for quieting inflammation. And after being used to treat rheumatoid arthritis, were introduced to the treatment of other autoimmune and inflammatory conditions. Dr. Walton was an early physician studying myositis, and in this monograph that they published in 1958, it says, it's apparent from the multiplicity of remedies previously advised in cases of dermatomyositis and polymyositis that no single treatment has been uniformly successful. And some might argue today that that's still true. And in this paper, what's sort of scary is these are what they listed in this paper in 1958 as drugs that were reported to be used to manage inflammatory myositis. Quinine, calcium, vaccines, prostigmine, quinidine, vitamin E, amino acids, vitamins, penicillin, sulfa antibiotics, another antibiotic, arsenic, salicylates, aspirin, fever therapy, testosterone. I mean, it's just amazing, the things that had been tried. And when steroids came around, they said, though the effects of treatment is unpredictable, all cases should be given a trial of cortisone or ACTH, which is the hormone that comes from the adrenal glands, or from the brain that tells the adrenal glands to make cortisol. So they said all cases should be given a trial of cortisone or ACTH. So is there evidence that prednisone works? Now, over the years, we've learned that and you've probably heard at this conference, that there's a difference. And just because something works for dermatomyositis doesn't mean it's going to work for polymyositis, doesn't mean it's going to work for inclusion body myositis. So this was some early work, and even before inclusion body myositis was recognized. But what this group of investigators in 1963, so this is only 10, 12 years after the Nobel Prize, maybe a dozen, maybe 10 years or a dozen years at most after it was introduced into clinical practice, what this group in California showed was patients with polymyositis, they found an excellent response in about 30% of patients. With dermatomyositis in about 35%. Cancer-associated myositis, nobody had an excellent response. So again, breaking patients down into subgroups, there's some difference. So this was excellent, good, fair, and poor. And so they tended to use prednisone at 50 to 60 milligrams a day, and honestly, it's what we still do. And then taper, and they showed that the muscle enzymes come down about a month, maybe a month and a half before muscle strength starts to increase. And this is not unusual to expect because basically you've got to get rid of the inflammation in the muscle before the muscle can regenerate. So it's the enzymes go down as the inflammation. Oops, I keep thinking I'm pointing on the pointer. I apologize. The muscle enzymes come down before the strength improves. But still in the 60s, there wasn't uniform acceptance, and there was uncertainty about the use of steroids. So this group from the Leahy Clinic in Massachusetts said, our results with corticosteroid therapy were disappointing. Our present practice is to reserve them for patients whose condition fails to improve or worsens despite, here's the current treatment at the time, rest, physiotherapy, and full doses of aspirin. And this investigator quotes, the value of treatment with steroids is not statistically proved. Because, however, many patients do respond favorably to this form of therapy, administration of steroids is generally advised in conjunction with other appropriate supportive measures. So again, they're talking supportive things, rest, physiotherapy, and not sort of viewing this as an autoimmune disease that needs immunosuppressive therapy. So here are some more recent data, still 20 years old. These came from the NIH, and they looked at subgroups of patients and looked at how different groups of patients responded to treatment with steroids. So here is the inclusion body myositis, and what you see is probably 40-some% had no response at all. Partial response in, 55%, nobody with complete response. In those with polymyositis, 20%, they said complete response, a good number with partial responses. With dermatomyositis, it's up to, about 30%, which they described as complete response. The connective tissue disease-associated myositis, so patients who have features of other autoimmune disorders, lupus, say, even a better response. And the cancer-associated myositis actually surprisingly showed some good responders. They also looked, you've heard some discussion about classifying these diseases based on the autoantibodies, and they also looked at all of their patients not by what disease it looked like they have, but rather what antibodies do they have. So patients with this SRP signal reactive protein, none had a complete response. Those who had Jo1 or one of the synthetase antibodies, the patients with Mi2, patients with this antibody, basically all have dermatomyositis. And those who had none of the myositis-specific antibodies. Now, this changes over time. Nowadays, we've identified at least a half dozen, maybe going on a dozen more antibodies. So again, the response differs depending on what group you're looking at. Now, the problem with prednisone, and that's what we'll get to when we talk about open for questions and have some discussion here, are the side effects from prednisone. And this study actually came from a young researcher working with Dr. Otis. He's pretty old too. This was published in '95. And what they did was to do a prospective study looking at a cohort, 257 patients they were seeing newly with polymyositis or dermatomyositis and followed them over time. They measured this HAQ disability index. This is a questionnaire form that tries to look at physical function of patients. It stands for Health Assessment Questionnaire. It was developed actually for studying rheumatoid arthritis and is very clear that it can predict who's going to do well and who's not going to do well with rheumatoid arthritis if you look at how that questionnaire, responses to the questionnaire change over time. We tend to use it for our patients with myositis, and that's what they had done. So they measured this functional, basically the functional ability, and having it go up is not good. Okay? So having this HAQ number go up means there's more disability. And what they found was that a lot of the disability was actually because of the prednisone. That they found that avascular necrosis, also called aseptic necrosis or osteonecrosis, is a condition linked to chronic steroid use where the bone is affected and actually areas of bone die. This often affects the hip. So seeing avascular necrosis or fractures, compression fractures of the vertebrae related to osteoporosis were some of the main factors for disability. So you've got this drug that works really well, but it's got a lot of risk, or it can cause a lot of complications. So in summary, we're getting down to the end of the slides, as you'll see here already. So I've got a lot of time to discuss. This isn't in anybody's textbook. This is what I draw for my patients all the time, and this is my conceptualization of treating inflammatory myositis, or for that matter, any autoimmune disease. So it's really to say that inflammation is the problem, and inflammation causes the symptoms. What happens depends on where the inflammation is. If you've got rheumatoid arthritis, the inflammation is primarily in the joints, and it causes swelling and pain in the joints, causes arthritis. With polymyositis, it's primarily in the muscle that the inflammation is, and it causes damage to the muscle with weakness. The muscle enzymes go up as they're damaged, but that inflammation is in the muscle. In patients with dermatomyositis, it's in the muscle and in the skin. Some patients with these diseases get inflammation in the lung, but it's inflammation causes the trouble. And the drug that's the most effective that we have currently for quieting inflammation, steroids. Prednisone, given intravenously, might be methylprednisolone or solumedrol, but steroids basically are very potent at quieting inflammation and therefore getting rid of the symptoms. But for most of these diseases, for polymyositis and dermatomyositis especially, our understanding is that something happens to the immune system. So the immune system is usually a good guy, right? Fighting off viruses and bacteria trying to get into the body. But there are conditions where the immune system somehow gets turned around, gets misdirected, gets tweaked. I don't know what happens to it, but it starts to attack the body itself and causes inflammation. So we view these as autoimmune diseases. Rheumatoid arthritis is autoimmune. So we see a lot of autoimmune diseases. But I tell my patients, we don't have that business cornered. There are a lot of other autoimmune diseases. There are autoimmune thyroid diseases, autoimmune gut diseases, Crohn's disease, ulcerative colitis. MS is an autoimmune disease. So the concept is the same, that the immune system somehow gets turned and attacks the body itself. And so to treat that, what we use are drugs that quiet the immune system. The problem is that we don't know what, for almost all autoimmune diseases, we don't know what has happened, what triggered this autoimmune response. There are some that are clearly caused by infection. The classic example is hepatitis C. Hepatitis C infection can cause the immune system to react to the virus, and actually the immune system sort of crosses over and causes an autoimmune reaction and inflammation. So in that case, I'd have one more arrow off to your left here that says infection causes autoimmune, causes this. So how do we treat it? Well, if there's a lot of inflammation around, you want to quiet that as quickly as possible, in my view, because we'll come back there. This isn't scripted. This is free form. But in that case, the treatment might be something that's an antiviral agent to shut down the hepatitis C. But for most autoimmune diseases, for dermatomyositis, we don't know what it is that has triggered this autoimmune process. So basically, the two main strategies that we have are, I guess there are three main strategies. You treat the symptoms, or you quiet the inflammation. But to my mind, what makes the most sense is you treat as far upstream as you can. So really, you use drugs to quiet the immune system. But since these can take a while to work, you want to quiet the inflammation with steroids. So I view that it's sort of a step approach. Well, some people will start with steroids alone, and for patients who don't respond, then add this. I tend to say, ultimately, we're going to need one of these immune-suppressing agents, but they take time to work, and while we're waiting for them to work, we want to quiet the inflammation, and that's where we use the steroids. One of the concepts that's coming into understanding these autoimmune and inflammatory diseases is that there are two main aspects to consider. One is what's going on right now. What is active? What activity needs to be quieted down? But the other is the concept that the active disease that's there now can cause damage, and you'd want to prevent damage. So the best, a few examples. One is patients who have lupus that affects the kidney. There's inflammation in the kidney, but as that inflammation goes on, those little filtering units in the kidney get knocked off. And yeah, you've got millions of them, but you can start knocking them off and they don't come back. That is damage. Those little parts of the kidney are damaged and don't regrow. So you want to quiet the inflammation that's in the kidney right now to improve the current kidney function, but also to prevent damage down the road. We don't think of it all that much with myositis, but it is to think, can we, at the panel discussion, I heard some talk about remission, and I think Dr. Levine talked about getting full strength back. I think that we look to get people as much strength back as possible, but I think as there's inflammation in muscle, one of the problems is that the muscle gets damaged, it gets scarred, and I don't know if it all totally 100% recovers. But again, it's the idea that we want to quiet the inflammation to prevent the damage to whatever organ, the muscle, the kidney, in arthritis, the joints. But it's thinking that we're treating right now to quiet the current disease, because we want to quiet what's active now, but we also want to prevent future damage. Now, the corollary is that if there has been damage that develops, there may be ongoing symptoms. Okay, so again, back to the idea of somebody with lupus, the kidney function, you lose some of those filter units, the kidney function doesn't come back to normal. The number that measures how the kidneys work, called the creatinine, tends to go up, and that's not going to come back. So that patient's going to have a high creatinine, but that doesn't mean that their kidneys are active right now. That means they've been damaged. Similarly, we see people who have myositis, who have, maybe were really weak, they get treated, they get strength back, but it doesn't go all the way up. Does that mean that it's still active? That's one of the real dilemmas of treating this disease, to say, are we now dealing with damage that isn't going to get better, and you're only risking more trouble if you push medicines? So what we'll come to is, what I view with patients in treating this is that it's really a balance of what are the risks of the immune suppressive drugs, what are the risks of the steroids, and at some point, yes, ideally I like to get my patients down to 0 prednisone, but I see a lot of patients in consultation who've seen other doctors and say, I've tried this, I've tried that, I've tried everything, I can't get off prednisone. And I sometimes have a realistic talk with them to say it might not be possible to get totally off prednisone. The question is, if you need it to quiet inflammation, and you want to, so we've pushed the immune suppressing drugs, but there's still some inflammation that needs some prednisone. If you want to get off the prednisone totally, you've got to push the immune suppressing drug harder. And at some point, there's more risk from doing that, and it might be less risk to stay on 5 milligrams of prednisone. I've got one patient who I've followed for a long, long time, and he had been doing well. He had, or has, polymyositis with interstitial lung disease and Jo-1 antibody, and he was on Imuran, azathioprine, one of the immune-suppressing drugs, and was on 6 milligrams of prednisone. And every time I saw him, he'd tell me he was doing great, tested his muscle strength, that muscle strength was great, muscle enzymes were absolutely normal. So I'd say, gosh, why don't we try lowering your prednisone? And remember the one time he said, I'll be happy to try again, but if you remember, the last 4 times it hasn't worked. Because my mantra always is, if somebody's doing well, taper the prednisone. And we looked back at his chart, and he said every time at 6 milligrams of prednisone, he is great. 5 milligrams, he starts to become symptomatic, and at 4, he's absolutely worse and weaker. So we just said, we could push the Imuran harder, but we were sort of running into trouble with blood counts going down, so we just left him at 6. And in truth, probably about 2 or 3 years later, he tapered himself off. So I don't know why he couldn't then, he does here, but it's the idea of, sometimes you're sort of striking a balance. So it's audience participation time. So have you used prednisone or other steroids? Or of patients, are those who haven't used prednisone? I guess is the other way to ask it. And not a hand goes up. Okay. And of the steroids, is it prednisone, dexamethasone? Anybody used? Prednisone. Medrol? They're all steroids. They're just different chemicals. So Medrol is also known as methylprednisolone. We think of it as sort of the equivalent dose of prednisone. So 5 milligrams of prednisone is 4 milligrams of methylprednisolone is 0.75 milligrams of dexamethasone. It's just a more potent steroid. And how about intravenous steroids? Nobody. One. Dexameth. Ah, okay, just as a pre-med. So steroids are good at quieting inflammation. We often use them to help prevent infusion reactions to various medicines. Yeah? Yeah. Okay. Yep. Yep. So the question was, prednisone's a Band-Aid, and how do you take? No, look, that's what I'm saying right here. I'm saying, I mean, it's not a Band-Aid, but it is very effective at quieting inflammation. And it's that the idea is that if this is an autoimmune disease, you've got to quiet the immune stuff. And if you can't do that, we use steroids to quiet whatever inflammation is left, basically. So it's not covering up the disease. It's actually treating the inflammation. It's just not treating sort of as far upstream as you'd like to go. So then the question is how to taper. I don't know, what did I put on here? Oh, actually, this is sad. Okay. So how to taper. So we talked about prednisone. So how much? 60 milligrams? People have been as high as 60? So here's the 100. Do I hear 120? 100, okay. Yeah, so sort of the typical, when we think of using steroids, I look at high dose, medium dose, and low dose. And again, this is my personal view, but I think most rheumatologists look at 15 and below as low dose, sort of 60 and above, maybe 40 and above is high dose. But usually we're thinking of 1 milligram per kilogram of body weight, and it's 2.2 pounds per kilogram. Okay, so 60 kilograms is 132 pounds. But we're usually thinking around 60, maybe 80. One of the things that seems a bit unique about these diseases is that some patients don't respond to 60 and 80, and you've got to go up to 100, 120. And why, I don't know. It just doesn't make a lot of sense to me, but we do. So then how long to taper? And that's where you get to looking at this as art more than science, in fact. That if you took all these people who were up on the panel today and asked them how they taper prednisone, if there were 17 of us, you'd probably get 20 or 25 answers. Because some people have more than one way. So the classic way of treating polymyositis and dermatomyositis was to use prednisone at 60 to 80 milligrams a day, and you continued that for 2 to 3 months. And for patients who didn't respond, you then added one of these immune suppressing drugs. And I think that is old-fashioned. And some of my thinking about this comes from how we've learned to treat rheumatoid arthritis, and that is the idea that what's key is the immune system, and you've got to quiet the immune system. Use the steroids to quiet the inflammation, whether it's the joints or the muscle, and you treat aggressively at the beginning rather than going slowly and let damage accrue. Again, this is sort of how I've come to treat this. So instead of saying we'll do 60 to 80 of prednisone for 3 months, and if you don't get better, then we'll add methotrexate or Imuran or one of those other immune-suppressing drugs. And I will give the disclaimer that what I do for IBM is different, and we'll come to that in a minute. So I usually start prednisone at 60, along with one of the immune-suppressing drugs, and I'm thinking 2 to 4 weeks at 60 rather than 2 to 3 months. And if the patient's starting to get better at a couple of weeks, then I start coming down. And I like to come down fairly quickly at the beginning, and then slow down and go to a sort of a long tail to it coming out. So I usually think 60 for 2 weeks to 4 weeks, and I usually drop to 40, although I've got a lot of colleagues who go to 50. I like to drop quickly, so I go 60, 40, 30, 25, 20. And then at 20, I mean, some is thinking, okay, is this person getting trouble from the prednisone, which is where we've got to go next? And do we have to come down quicker? But I sort of shoot to get to 15 or 10, and at that point start thinking that we drop. So the early drops might be every couple of weeks, but as you get down to 15, what I think is low dose, then I say, okay, let's go, we can probably be a month at 15, and then I go to 12 and a half for a month, and then get down to 10 for a month or maybe a couple of months. So we heard about, again, back to the idea of remission. I think I'm making this talk more about treating rather than about prednisone. I apologize. We'll get to prednisone. I come down very slowly after getting to 10. And it differs. Patients who have interstitial lung disease, I think, do better staying on low-dose prednisone rather than trying to get off altogether. I'm not sure there's data for that, but it's been my sort of feel with the patients I take care of. So I tend to leave them in the 5 to 10 range. But people who don't have interstitial lung disease, I'm thinking after maybe 6 months or so, will start coming off. I mean, this is a chronic disease. It's not going to change quick, so we try to get people off. And then if I've gotten somebody off prednisone and their disease is staying quiet, what I do is to follow them, and so they're still on methotrexate or Imuran or Celcept or one of those kind of things. After a minimum of 6 months, and I usually like to go a whole year if things are good, I say, you know, there are some patients who have a single flare of this disease. It goes away and doesn't come back. Unfortunately, it's not as many as we'd like, but there are some people who do. There are other patients who have more chronic, ongoing disease. But if somebody's been under control with the immune-suppressing drug after 6 to 12 months, I say, it's your choice. We can either stay on this drug because you seem to be doing well, or we can say maybe you don't need it anymore and you do just as well with less. And I tell patients it's a philosophic discussion. There are some patients who say, I remember how sick I was. I never want to be like that again. I'd just as soon stay on the medicine. And there are others who say, I hate taking drugs. Let's try to get off it. And so, and I'll support either one. I usually encourage at least once trying to get off to see how things do. So prednisone. Okay. What side effects have you experienced from steroid treatment? I realized last year I had the computer up here and I typed them all. And because when I went to recycle this, I had all the responses from last year typed in. So side effects. Moon face. Moon face, buffalo hump. I heard redistribution of weight and overlapping belly. We'll count those as the same. Weight gain. Yeah, so this was about developing neuropathy in the feet. I think that's unusual with polymyositis and dermatomyositis. You see some neuropathic features in patients with inclusion body myositis. The other issue that sometimes get raised, so neuropathy just means nerve damage, and a lot of things can do it, from typical things, lead poisoning. No. With steroids, the one that often gets potentially tied to it is thinking that prednisone can cause diabetes. Diabetes causes neuropathy. But other things can cause neuropathy, including weight changes. Sometimes weight loss makes it easier to compress a nerve to cause neuropathy. So other side effects. Insomnia. So is that common? Yeah. Dose-related? No? Yes, I usually see it at high doses in patients, and after we get down to lower doses. I've got the one story. I had a patient who was on 60, and she came back and she said, my house has never been cleaner. I can't sleep at night. I've got all this energy. So, emotional. So emotional lability, moody, snapping at people. Okay, crying. Yeah. Okay, so emotional, osteoporosis, bruising, and what? Yep, bruising and thinning. These are great. They're sort of convergent. Okay, wait a minute. Bruising, thinning, hypertension, high cholesterol, diabetes, So here's a question about recommending calcium. So this is sort of the next slide, but that's okay. It's okay. This all runs together because it's coping with it, because I didn't ask people what they do about the emotional stuff and the not sleeping. So with osteoporosis, what do you do? Yeah, so calcium, vitamin D, one of the bisphosphonates, the Fosamax kind of drugs. The standard answer, so some depends on calcium intake from the diet and things on that order. My standard is to tell patients who are on high-dose prednisone that they should be taking about 1,200 to 1,500 milligrams of calcium a day, and that the calcium should have vitamin D with it. And usually, if you get a product that's calcium with vitamin D, if you get the calcium to that level, you get the right amount of vitamin D. I've generally had people stay on it. Now, in the news, half a year ago or something, I've forgotten how long ago, came out the report that calcium's not good for you, right? I'll get there in a second. So what do you believe? So everybody, women, postmenopausal women were told to take calcium. My wife never did. She saw this thing on the news, said, see, I was right. So it's hard to know. But in general, I've usually had people stay on the calcium, and if they get down to a low dose of prednisone, it probably makes sense that they could probably taper off of it. Yeah, so the question was about vitamin D. Is the amount in the supplements enough to replace? Testing vitamin D levels has become quite hot these days, and it used to be that we just recommended calcium with vitamin D. Now there's encouragement to measure the vitamin D levels, and patients who are really low in vitamin D need high-dose replacement, thinking 50,000 units, 50,000 once a week for a month or two. And usually, though, once you get people supplemented, if they've been really low, you get them up, and then it's about 1,000 units a day of calcium to be on. For people who weren't really low, it's typically 800 to 1,000 a day. And like I say, if you are taking a calcium supplement that has vitamin D, the ratio's right, that if you're at 1,200 to 15, you're at 800 to 1,000. Moon face, buffalo hump, weight gain, neuropathy. Insomnia. I was going to say I can't read my handwriting. Insomnia, emotional, osteoporosis. Yeah. Speaking of which, I see patients with tremor. So bad handwriting. Cataracts. Going along with cataracts, glaucoma. Yep, and vision change comes from the cataract and the yep, and the vision change seems to be similar to the weight gain. It's really sort of accumulating fluid in the eye, and the pressure in the eye goes up. But we see patients who get some vision change just without having glaucoma, and I usually advise patients not to go get their eyes checked and plan to get new glasses if they're on 60 of prednisone. Wait till it comes down. So skin thinning and bruising and abrasions. Yeah. Yeah, no, striae, stretch marks come with it too. Yeah, skin tears. I mean, as the skin thins, and you get these abrasions or tearing it easily. Right. So other blood thinners, whether Coumadin or aspirin use, I think aggravates the bruising a lot also. Yeah. So the question is about calcinosis that comes with dermatomyositis especially. The prednisone doesn't cause that. Treating calcinosis is one of the most difficult parts of this disease, and there's no clear treatment. There's a long list of things that have been used, including Coumadin, warfarin, blood thinners. It's not clear what helps. If anything, people suggest that developing these calcium deposits comes as a part of having active disease, and that the treatment is to treat more aggressively. She has PM, has polymyositis. It's interesting. I think it can happen. It still sometimes gets to the question of what disease it is and how comfortable we are knowing what. And yeah, we struggle with classification. It's a great question. I don't think so. So there are, how to answer this? We see calcium deposits in a variety of abnormal situations. So patients who have heart disease, nowadays sometimes they'll do these CT scans and they get the coronary artery calcification score. So we see calcium deposited in the arteries of patients who have vascular disease, and we will sometimes see calcium deposits that go with tendon injuries. We see calcific, it's called calcific tendinitis. What causes the calcium deposits? I don't know. Here we think that it's inflammation. With the myositis, we think it's inflammation related again. Yeah, so the question is whether calcifications in the breast can be a precursor to breast cancer or an indicator that it may be coming. And honestly, it's out of my field and I don't know, but like I say, in general, to say if it was there because there were abnormal cells causing a cancer that maybe stirred up some local inflammation, and that the calcium deposition is sort of a response of the body to the inflammation. I don't know. It's definitely an unknown area. So what are, yeah. So this was the question that steroids are very good at quieting inflammation, and so this is a good thing to get to. So sometimes things like carpal tunnel, if it's caused by inflammation and you can treat the inflammation, that gets better. Sometimes people with disc disease get treated with steroids. You get injections of steroids, and I've seen patients put on high-dose prednisone have some improvement of some of the disc-related back pain, but it's sort of, yeah, taking advantage of the fact that prednisone quiets inflammation. Now, yes, so now back to 5 milligrams of prednisone, the knee's starting to hurt again. Yeah, so that is actually one of the things that I see. There are some patients who can't get off prednisone. You get them down to a low dose, and you just can't get them off. And it's like the patient I told you was good at 6, and you try to come off, and it gets worse. So I think it's one of 3 things. Either there's enough of the disease inflammation going on that still needs a little bit of prednisone, or that little bit of prednisone is actually treating some of the osteoarthritis, the wear and tear arthritis that they've got in other joints. And when you try to take them off altogether, those joints get achier and people complain more, and you end up using it really not to treat the myositis, but you're using it to treat some of those other musculoskeletal symptoms. The third that people debate is whether some patients lose the ability to make prednisone. So that how to describe this? When you take prednisone for long enough, your adrenal glands shut down and stop making steroids, stop making cortisol, which is what our bodies make, which is equivalent to prednisone. So the body gets prednisone, senses, oh, there's enough steroid around, I don't have to make cortisol anymore. And so the signal for the adrenal to make cortisol goes away, and in time, the adrenal glands stop making it. And I liken it to a factory. You know, if you shut the production line down for an hour or so, it's okay. But if you shut down for a week or two of vacation, you've got to rebuild the machinery and get it back together. So that's one of the reasons that you're told not to stop prednisone abruptly. So you don't want to stop it abruptly because, one, the disease may flare because it was doing some good, but it's also that after you've taken it for 2 to 3 to 4 weeks, you know, people are different, but certainly after a month at a good dose, the adrenal glands stop working. And if you stop the prednisone, people feel just, well, they feel just crummy. And it's that people, so there's a condition called Addison's disease where the body doesn't make enough cortisol or doesn't make any cortisol. And patients with that generally are achy and stiff. And it's the kind of things that a lot of patients experience when tapering prednisone, when going down, especially at low doses. So our bodies make on average, the average person makes cortisol that's the equivalent of about 7 milligrams of prednisone a day. So if that's the case, it actually doesn't make any sense to me why we can get somebody down to 5 or 6 milligrams of prednisone and we can't get them off. Because at that point, it seems it's just replacement doses. But there are an awful lot of people who kind of get stuck at low doses. And that's what makes me wonder, is it that really those low doses are treating something else, or is it that that person's adrenal glands have sort of lost the ability to make as much steroid as they did before? And we don't know. Go ahead.
Do you see as much like bone degeneration with your younger patients? Like if I've been on it for almost a year now, do I have the same kind of implications as somebody that's a little bit older?
Yeah, so prednisone, steroids cause bone loss very rapidly, and it happens at younger ages as well as old. I don't know that the rate of change is different based on age. I think it's just that there's an issue that older people, older women especially, have other reasons. You know, it can be postmenopausal bone loss, so there are other reasons for bone loss. But I think that the rate of loss is equivalent. It's just that it's... Yeah, so the question is about doing a DEXA scan, and it gets back to that question of who to treat with bisphosphonate, one of the Fosamax kind of drugs. I have some colleagues who put every one of their patients on one of those drugs. I tend to check the bone density. And so osteoporosis is really low, right? So osteopenia is low, but not as low as osteoporosis. Clearly, if somebody's on prednisone and has osteoporosis, they ought to be on one of those drugs. If they have osteoporosis, they probably ought to be on it if they're not on prednisone, okay? But if on prednisone and you're in this sort of low but not really low range, then most would use one of the bisphosphonates. It's the Fosamax kind of drug, whether it's the oral one or there are intravenous ones that only have to be done once a year, and probably doesn't matter which.
Is there an advantage to taking prednisone every other day once you've tapered down to a certain dosage?
Great question. So it's about taking prednisone every other day. With prednisone, for a given dose, there's more bang from it the more often you take it. So we talked about 60 milligrams of prednisone, and sometimes I start at 20 milligrams 3 times a day, which has more effect than 60 milligrams once a day. Mm-hmm. And so for people who are really active, we'll often start with it as a split dose, and the first taper, so to speak, maybe going from 3 times a day to the same dose once a day, and then coming down. So some people have advocated using it every other day. I don't do that very often. I think I've seen it done, and I think that my opinion about it is probably driven more by experience with rheumatoid arthritis. In patients with rheumatoid arthritis, it's pretty clear that every other day isn't sufficient. It's probably better here with myositis, but I tend not to do it. Part of it is to keep things simple. To say, if you've got to take something every other day, to remember which day's on, which day's off, unless you fill up a pill box. The other that we could mention is, I don't know if people have talked about using trimethoprim sulfamethoxazole, Bactrim or Septra. That one of the issues is concern for patients who are on high doses of prednisone, especially with an immune-suppressing drug, for a particular kind of pneumonia called Myositis. And our lung doctors get referred a lot of patients with bad lung disease, and they're pretty insistent that we use this antibiotic to prevent this particular kind of pneumonia. The issue is usually when prednisone is above 10 to 15 milligrams a day. Some of the lung doctors say 10, others say 15, but certainly up around 60. Where I was going with this discussion, I often get off track, was that you can either take a single-strength pill once a day or a double-strength pill every other day. And I've just found it a lot easier for patients to take something every day rather than try to remember, is it the on-day or off-day? So I tend not to use alternate day steroids. People who do use it claim that there's a lower risk of side effects, and it's, like I said, the more frequently, the higher the more bang you get from the drug, good and bad.
Hi, just a quick question. So for the patients who can't seem to get off prednisone, about what percentage of all your myositis patients do they make up? And the second part of that is, how long can they be on prednisone until you get worried? Like, can they be on for 5 years, 10 years before the long-term effects start to get...
So the question is, what percent of my patients are on prednisone? I don't know how many are on low-dose prednisone. As I said, I tend to keep people with interstitial lung disease on low-dose prednisone, and my practice is probably biased toward having people with more severe disease sent in to see me. So I probably tend to have more than, say, an average practice, neurology or rheumatology. But I always keep coming back here saying, what's the balance of, if we want to get off, how hard do we have to push? Or alternatively, what are we willing to put up with? What kind of inflammation? Maybe the rash is worse because we want to get off prednisone. I put that in the context of thinking that it's still active disease, and at some point I'd like to quiet active disease to prevent damage. The other part of the question was how long you can stay on low-dose prednisone and not get in trouble, and it's all relative. I'd like to get people off as quickly as possible, but if you can't, you can't. And then at some point it gets to say, okay, how bad is what's going on, and can we put up with it? So I've got a woman with, and I keep giving lupus examples, but this woman has, some patients with lupus have their platelets go down, and you need your platelets to clot. And we've tried all kinds of immune-suppressing drugs, and they don't work. The only thing that works is prednisone, and it takes 20 of prednisone. And, but we can't do anything else. And if we lower it, the platelets go down and she's had trouble with bleeding. So sometimes it is to say, how bad is bad and what are we willing to put up with? So in that circumstance, she's getting all kinds of steroid side effects, but I've just not found an alternative is the problem. So a lot of these side effects are dose-related, like the insomnia, the moodiness are with the dose. Some are the combination of dose and duration, so that the osteoporosis is kind of a cumulative thing. I usually see the moodiness and the insomnia there with high doses, and that goes away as you come down. Might not be everybody's experience. Here we've got
We can probably do one more question. It's 5 o'clock now, and there are other sessions that are going to be starting.
In lowering your prednisone, does it affect your CPK level?
So the question is lowering the prednisone and affecting the CK level. I say CK, some CPK. So it is to the effect that it quiets the inflammation in the muscle, the enzymes come down. So it is treating the disease. It's treating the inflammation. It's not treating sort of the upstream cause. But yeah, that's typically what we expect is to see things improve. And so how do you measure improvement? Patient's functional ability, muscle enzymes, muscle strength, all sort of core measures to it.
One more. Dr. Ytterberg, several doctors, including yourself, the strategy is to get somebody off prednisone as soon as possible. And a couple of the doctors have said they would rather see somebody get, they really kind of fear prednisone almost. They want to get them off it as soon as possible. What is the real danger, the real fear? Is it an exacerbation of the side effects? Is it just a worsening of the side effects? Is it particularly the bone injury? What is the real danger of prednisone?
It's all those. And
okay, so honestly, there's nothing, it's the side effects, in other words.
Yeah.
Okay. There's no other fatal kind of, I mean, it's...
So the one that didn't get mentioned as I look at the list is infection.
Okay.
That it increases the risk of infection. So if we say what is, are there potentially fatal side effects from prednisone? Well, I see people with bad osteoporosis getting fractures and then getting a pulmonary embolism. I mean, there are scenarios like that, but probably infection is one of the biggest risks of really bad things.
Thank you, Dr. Ytterberg.
Okay, thanks for having me.